Good morning, ladies and gentlemen. Thank you, Mr. Chairman. A pleasure and a privilege as a pediatrician to come to close this meeting. And if I may ask, are there any pediatricians in the audience?
Pediatrician?
As I suspected,
so.
I'm the only one. Perhaps maybe because I'm the only pediatrician who doesn't have a bad word for the obstetricians. Well, I'm going to talk to you on the perinatal care of multiples. If I can have the... Oh, good, thank you. And I would like to endorse my talk, as it is the controversies, a meeting on controversies, on the multiplicity-related disorders, the controversies, and then, of course, the outcome for the offspring. Well, we all know the many reasons why multiple pregnancies are such and so often complicated. And they stem from many different reasons, and the reasons and the problems are not just for the mother, but are also and especially for the fetus and for the neonate, and later for the child and the adult. Now, what about the controversies? I would like to endorse mostly two subjects. One is on the antenatal corticosteroids, and of course, some of the previous speakers, and especially Isaac has already mentioned, the mode of timing gum delivery, and I'm therefore just waving on that. But let's concentrate on antenatal steroids. And what do antenatal steroids do? Well, we all know they do a lot of good. And they do indeed induce fetal lung maturity. They certainly do reduce neonatal mortality, intraventricular hemorrhage, even perhaps necrotizing enterocolitis, and maybe some problems when it comes to the increased chronic lung disease, especially the new bronchopulmonary dysplasia. And of course, a major concern is what is the neurological outcome of this offspring subject to antenatal corticosteroids. Well, but we know that antenatal corticosteroids are certainly a good thing, so please do use them. But what do we actually know about antenatal corticosteroids in multiple pregnancies? Do we know a lot? I don't suppose we do. Actually, we extrapolate from single pregnancies into multiples when it comes to giving antenatal corticosteroids. And the reasons for those questions are, do twins mature earlier than singletons? Well, you've seen from previous speakers, especially from Isaac, that they possibly do. But at what gestational age do they actually start accelerating their maturation? Again, will zygosity affect maturation? Is it the same to be mono or dichorionic? And what if they are different sexes? Do female fetus mature earlier than male fetus? And what will be the recommended dose? Will it be the same as for singletons? Or do we halve the dose? Or on the contrary, will we double the dose? And what and how do we know that each twin will receive the required dose? And again, do boys need half the dose? Do girls need it more? And yet, we do exactly the same as we do for single pregnancies. And we're talking about trebles and quads. So, let's try to answer some of these questions. Let me show you what has happened. And indeed, it has been shown that beta-methysons in higher order pregnancies is in fact associated with the increased uterine contractions, preterm labor, and therefore, at least back 15 years ago, maybe corticosteroids were not such a good thing for multiples. And indeed, again, apparently, there has been no benefit from antenatal corticosteroids, especially in terms of reducing respiratory distress syndrome. And once again, the same question as to lung maturity, which is the main reason why we give antenatal corticosteroids. And indeed, overall, it does appear that corticosteroids are not such a good thing. And the reason for that was perhaps due to the increased blood volume that the shorter half-life of beta-metazone in pregnancies was perhaps responsible for the required and achieved therapeutic levels. But there comes the good news. And the good news are that indeed, in spite of all the questions, in spite of all the observations, changes in fetal heart rate variability, body and breathing movements in twins following beta-metazone apparently provides evidence that antenatal corticosteroids do actually reach the fetus. So that's the good news. And the good news again from ISAC data some years ago is that the effect of antenatal corticosteroids did actually decrease with plurality, but at least there was some benefits from antenatal corticosteroids in reducing the incidence of respiratory distress syndrome. And furthermore, it also has a positive effect upon reducing interventricular hemorrhages. So that's the good news. Maybe not as effective as in singletons, but most definitely, certainly, still do work, and data again does to show that antenatal corticosteroids are here, and indeed they do seem, in spite of all the problems, in spite of all the questions I raised, that in actual fact, please do continue to use antenatal corticosteroids in twins. Please do, even though we may not know the exact timing, the exact dose, but that certainly is something that we do. And as to when do we start and when do we stop using antenatal corticosteroids, admittedly, I think really that although at the low extremes of prematurity, there might be some doubts, but at least for those that matter between 32 and 36 weeks, they certainly are worth using. And again, I think sex is perhaps not quite so much of a problem. So, antenatal corticosteroids, ladies and gentlemen, in spite of all the questions, in spite of all the doubts, is still a good thing, even for multiples. Now, the mode and timing of delivery. I'm a neonatologist. Forgive me for that, no one is perfect. But, as you see, a lot of controversies. Isaac has discussed quite eloquently whether or not one should really do cesarean sections and when should one really deliver these babies. And of course, the major problem is when we're talking about monozygotic and dichorionic, because for the dizygotic and for the monochorionic, the fetal and medical reasons will determine that. I'm going to go through this quickly because, as I say, I will just summarize what Isaac has quite rightly said, and therefore I don't think we're going to waste too much time on the timing and the modes of delivery, because I think we won't do anymore. Now, but there is one very important question when we're talking about cesarean section. We saw that for the fetus, usually, and for the neonate, the medical conditions we deliver. But what about the mother? The mother of multiples, do they actually benefit from a cesarean section? And that is a question that you obstetricians will have to endorse to yourselves. And admittedly, if we are faced with multiples, is it better an elective or wait for problems and go into an emergency cesarean section? Do I have answers to these questions? I wish I had, but from the perinatal viewpoint, I think again, unfortunately, each and every case will have to be discussed daily in our clinical practice and decide together, not obstetricians on one side, neonatologists on it, but together, and we should really endorse the subject and the topic each and every day in our own clinical practice. always with an open mind that each and every case is a different case. And the timing of delivery, again, Isaac has already mentioned, because mostly what we're talking about are the monozygote, monochorionics, and therefore let's go over this. And you are obstetricians, you deliver the babies, and you give them to us, the neonatologists. And I think it is really particularly important that you yourself should know what's happening to the result of multiple pregnancies when it comes not just to fetal death, not just immediate outcome, but maybe what happens later on to these babies, to these children. And when it comes to the immediate neonatal problems, admittedly, unfortunately, these are facts, and the facts are that neonatal deaths, stillbirths and neonatal, are obviously considerably higher, has always been, in twins rather than singletons, due to intrauterine asphyxia, and perinatal mortality rates are usually 5 to 6 times greater than singleton pregnancies, and the cost of prematurity, when it comes to overall, is 5 times greater, and when it comes to twins, doubles, and triples, is almost 100%. Again, a major problem here with low birth weights and intrauterine growth restrictions, once again, especially with higher order pregnancies. And so the immediate neonatal problems, if not immediate intrapartum problems, we have all these complications, which are a lot more frequent, far more common in multiples than they are in singletons, from respiratory distress problems, necrotising, interventricular, metabolic adaptation, sepsis, and so forth. And not least important, certainly for me as the head of the department, how much do I have to pay for multiples? And indeed, I think it is really a considerable toll when it comes to financial and human resource dealing with multiples, not just twins, but higher orders, triples, and more. Now, admitting that they do actually survive, which fortunately the great majority do, the problems do not finish with the neonatal period or even with the perinatal period. And indeed, we know that the high price to pay is always considerably high. Higher for multiples than they are for singletons, in terms of cerebral palsy, in terms of neurological outcome, neurosensorial, and indeed all the data shows that from cerebral palsy to psychomotor development delay to neurosensorial to learning and behavioral problems, unfortunately the higher orders, and the more the higher order, the more the problems in the mid and long term. This is really always a major problem when you, the obstetricians, are faced with multiples, and with the neonatologists are faced with the result of multiples. Always a very bad outcome compared to singletons. Whatever we may do, we really not always particularly said what happens. But why does actually really happen? Why do we have all these problems of intrauterine death and, of course, the outcome? Is it just because of prematurity? Is it because just the low birth weight, and especially for the discordant twins? Or could it possibly be that is the result of chorionicity and thromboemboli, shunts, and so forth? The fact is that. What about the outcome between spontaneous occurring multiple pregnancies and iatrogenically induced multiples? And indeed, I think really the most important message when it comes to spontaneous versus induced multiple pregnancies, and in spite of all the problems, in spite of all the concerns, the good news is that although there is an increased ratio of cesarean sections for the iatrogenically induced multiples, at least in the immediate term, there's no appear to be a much worse outcome for the assisted reproduction techniques multiples, and I think the problem is, unfortunately, that at least the immediate outcome is very similar, or even perhaps better in the induced multiples than the spontaneous, perhaps due to dichorionicity as opposed to monochorionicity. So that's at least the good results. Does that mean to say that we, the pediatricians or the perinatologists, are happy with the epidemic of multiples? Unfortunately, for most of us in this part of the world, at least now there is legislation to prevent higher orders, triples, quads, and so forth. But when it comes to multiples, when it comes to twins, at least the good news is that for ART the results are not worse. Now, one last word about a major problem, at least a social and a health problem for the survivors of fetal and neonatal mortality. And this is what happens to these children when they grow up. And these children do grow up, fortunately. And even if they don't have any major problems in terms of cerebral palsy, neurosensorial deficits, learning difficulties, adaptation to society, these children, multiples, are still at an increased risk of what it is nowadays, certainly for me as a pediatrician, following these children up to the age of 18 and then seeing them as young adults, in the increased risk of the adult metabolic syndrome, of obesity, insulin resistance, or overt type 2 diabetes, hyperlipidemia, high blood pressure, cardiovascular strokes, and so forth. This is a major problem. And indeed, remember, you are certainly very familiar with Barker's hypothesis of programming, and indeed, multiples are not free from fetus adaptation to an adverse intrauterine milieu, and then the price for survival to be exactly that of programming, and indeed the risk. And the risk and the evidence is quite substantial that twins, in spite of chorionicity, will survive and will perhaps have, once again, all the features and all the characteristics leading to obesity, hyperlipidemia, hypercholesterolemia, high blood pressure, insulin resistance, and so forth. And this is really, and has been shown repeatedly over and over again. Although there are certainly a few ones who will dispute that maybe with proper follow-up and care they will probably survive and they will probably go without things. So programming, although inconclusive, nevertheless should be still a major problem. And this is a question of nature, or is it a question of upbringing? Many questions, ladies and gentlemen. This is a program on controversies. I showed you in summary what are the problems and the predicaments of multiples, but let me show you, ladies and gentlemen, that fortunately some of the multiples are really it. That is Francisca, that is Elizabeth, yes, and they are mine. Thank you.